And again, welcome to our February meeting. Tonight, I have the pleasure of introducing Ron Winokur. He's a fellow city faculty member at Jefferson University, and he's going to be speaking on advanced venous intervention. I'll just kind of let him get into it. At the end, for those that haven't attended prior meetings, if you have a question, just put it in the Q&A section. We'll go over it at the end. Yeah, welcome, Ron.
Thanks so much. Thanks for having me. It's nice to be at Pairs. I wish I was somewhere where I could see you all, see how many people are here, figure out who I'm talking to and what the audience is, and interact with you guys more. But Zoom it is in our world in 2021. So feel free to interrupt me while I'm talking. If you want to, I'm open to a lot of questions at the end. My goal of today's talk is really to talk about advanced venous interventions and how they're complex and interconnected. I want you to come out of this and realize that venous disease doesn't exist in a vacuum. And if you have a patient with varicose veins, you have a patient with spider veins, you have a patient with pelvic venous disorders, you have a patient with DVT, you have a patient with leg swelling, all of these components can be interrelated. And so that's really the thrust of what we're going to talk about today. All right, here are my disclosures. So when I map out and think about venous disease in my head, here's my broad topics of choice and how they all map out. And this is more of the segmental view of venous disease. And it doesn't go after what I was just talking about, the interrelated components, but it lets you get a sense of everything that we're dealing with. So you're dealing with deep venous disease, which could be acute or chronic obstruction, and that chronic obstruction can be post-thrombotic or non-thrombotic. Then you have deep vein reflux, which we don't deal with a whole lot yet in the IR space. You have superficial venous insufficiency, which has been tried and true treatment that we've done for many years in IR, great catheter-based techniques, but it's not as simple as just axial reflux. And you really do have to think about how it's interconnected with pelvic veins, as well as perforators and its connections to the deep veins. Then you have pelvic venous disorders, and pelvic venous disorders are their own complexity. Those of you who know me well know that this is an area of interest of mine. And so there's lots of interconnected components between obstruction and reflux that lead to pelvic venous disorders and pelvic pain in women. And then lastly, you have varicoceles that again kind of are similar to pelvic venous disorders in women, but really just sit on an island because they're less interconnected and they really stand alone. And really what we're talking about is something more like this, rather than the broad algorithm of all the different diagnoses that you can come across in vein disease. You're really talking about all these things and how they interact. I'm sure everybody who's listening today has seen a case who has deep vein obstruction. Maybe that's iliac vein compression or May-Thurner syndrome, as well as left lower extremity varicose veins. Or maybe you've seen a patient with a left leg DVT and chronic obstruction and superficial venous disease and varicose veins that you see on their leg, and maybe even axial reflux. Maybe you've seen somebody with deep vein obstruction, May-Thurner syndrome, and pelvic pain and pelvic venous disorders. So you have this combination. Or maybe you've seen a patient with a DVT who has recanalized pelvic veins, and I may show you an example of this later. And they may have pelvic pain from their collaterals of their DVT. And then often we can have interconnections between the superficial and the pelvic system. So you can have pelvic venous disorders of any variety, obstruction or reflux, and it can escape into the superficial system of the legs. And so you can have both deep pelvic venous disorder in the pelvis and chronic pelvic pain, as well as varicose veins in the legs, and their presentation is going to vary. And then in a very small lucky few, they're going to have all three. They're going to have superficial disease, pelvic disease, and deep obstructive disease. And so you have to think about all aspects when you're working up one of these patients. If we look at it more in an algorithmic, instead of a diagnosis standpoint, if we look at a map of the veins and we try to figure out how they're all interconnected, it becomes even clearer. So here's a nice diagram that I have that looks at the pelvic venous vasculature. And you have the IVC for the younger residents and early trainees in the audience. The IVC, the left renal vein runs between the aorta and the superior mesenteric artery here, which can be a compression point. Nutcracker syndrome can lead to backfilling into the renal reservoir, renal hypertension, or it can collateralize through the left ovarian vein into the pelvic reservoir and into pelvic varicosities and escape either across the other side into the right ovarian or into either of the internal iliac veins. And then on top of that, you have obstruction processes that can happen here at May-Thurner, where the right common iliac artery crosses in front of the left common iliac vein, and you can get backfilling into that pelvis as well, and then collateralization across to the other side. And so those are all interconnected, but then not only does that happen, but then when you get to this pelvic reservoir, these pelvic veins escape out onto the leg reservoir in 4 different pathways. And they can escape out through pudendal veins, obturator veins, gluteal veins, and so then you can end up in reflux in the superficial epigastric vein that then joins the great saphenous vein and refluxes all the way down the leg and leads to varicosities or lower extremity pain. And similarly, we have interconnection points in the leg. Here's a deep perforator vein as an example in the posterior thigh, where the small saphenous vein, in at least a quarter of cases, bypasses the saphenopopliteal junction, goes up in this thigh extension, and then enters through this deep perforating vein into the femoral vein. And so you have interconnected components, and you have multiple deep perforators throughout the leg that connect the superficial system to the deep system. So if you have superficial reflux, it can sump from the deep system and lead to deep vein insufficiency or deep vein reflux. Or if you have deep vein reflux from an obstruction, maybe you can have retrograde flow and an incompetent perforator that then recanalizes backwards, retrograde into the superficial and out the superficial system to bypass the area of obstruction. So it's clearly all interconnected. And what I love, one of my favorite aspects of venous disease, I'm an engineer as a background before I went into medicine. And my favorite part of venous disease is it's thought-provoking. You get to think about the physiology. It's flow physiology and flow dynamics. And you get to think about where the pressure is highest and where the pressure is lowest. And that's going to clearly tell you where the blood is going to flow. So you can think clearly about the process and interconnect all of these segments to try to come up with the best treatment algorithm. So not only is this complicated, but when patients show up to your office, it's not necessarily super clear what they have. I did a study many years ago when I was a very early attending, trying to see if faculty members could predict the source of varicose veins. So I took pictures like this of a lot of patients that I saw in the office who had varicosities, skin changes in different parts of the leg. And I didn't tell anybody the ultrasound findings, and I had them look at the leg and tell me, what do you think is causing this? GSV reflux, SSV reflux, anterior accessory GSV reflux, deep venous insufficiency, obstruction. And it turned out about 20 to 30% of the people when I gave them the survey, they were accurate and correct 20 to 30% of the time. When I took general IRs, if I took vein specialists, they were a little more accurate. They were probably 50% accurate, but not great. And you really do need an ultrasound to understand what's going on in the venous system to figure out what the pathophysiology is. So this is an example of that. So you may see a patient who looks like this, and your first instinct is, I see some varicose veins in the calf. I see corona phlebectasia at the ankle, clear spider veins here. I see this very well-defined area of eczema. It's not quite ulcerated. Maybe we can call that pre-ulceration. There's some redness and duration there. So severe venous disease, but you don't know, does this patient have iliac obstruction or just superficial reflux? Here's another patient that looks kind of similar to the last one. You can see he has a fairly large leg on the right, but he has very similar skin changes near the right ankle. He's got corona phlebectasia. He has eczema. He has induration. He has discoloration. So how can you differentiate this last patient, who I'll tell you does have superficial venous insufficiency, and this patient who has an acute DVT? And it's very hard on the surface, and that's why we have to be skilled at our image interpretation and how those systems are interconnected. Then you can have a patient who looks more like this, who has bilateral lower extremity swelling, skin ulceration in both legs, clear severe disease, but again, we don't know what we're dealing with. And it could be a combination of superficial and deep disease. I don't know if you can make it out, but you can see some varicosities here. You can definitely see some spider veins on both calves. And then you can have patients like this who come into the office and they have clear varicosities on the back of the leg. And your initial thinking is, well, this is clearly varicose veins. This is a young woman in her 30s who's had 3 prior pregnancies. It's hard to visualize on these images alone, but if you start to look, you can see on the upper inner thigh, these veins keep going up into the inner thigh. And the first thing that should catch your mind is that these are on the posterior thigh and posterolateral area of the thigh, and they're running in from the inner thigh. Clearly, this is not a normal orientation for GSV or SSV reflux. And so here's a patient who has pelvic-derived varicose veins. She also presented with pelvic pain in addition to her varicosities in her legs. So venous disease evaluation clearly requires clinical decision-making. This requires us to be clinicians at our very best, to be history takers, to interview patients and understand what it is that's bothering them and why they present to our office. It's not nearly as clear as somebody who comes from a multidisciplinary tumor board with an HCC or an RCC or metastatic uveal melanoma who clearly needs an embolization. Here we get to be in the driver's seat of making the diagnosis and making the decision on how to manage them. So what better way to go through this, but here's a recent patient that I saw for presentation. So here's a 67-year-old male, history of factor V Leiden, protein S deficiency, so clearly prothrombotic. He's had multiple DVTs in his past, starting in 1972 after an appendectomy. And this is what he looks like when he joins the office, when he comes into the office. He has a very swollen right leg with redness. You can clearly see discoloration. You can see spider veins all over the ankle here, corona phlebitictasia. I will tell you on exam, the skin was indurated and thickened. So he clearly has advanced venous disease. The question is, what is the source of his advanced venous disease? Everybody's probably thinking, well, it's clearly his DVT history. He's had DVTs since 1972. But when you look at him, the first question you're going to ask, I see these varicose veins in the upper thigh. You can see them, me pointing to them with the arrow, and they're clearly seen in the pictures. So is this deep? Is this superficial, or is it both? Here's his Villalta scores. So Villalta on the left is 1. His Villalta on the right is 15. He has pain, he has cramps, he has heaviness, he has severe symptoms of venous disease. And a VCSS score, again, that's elevated on the right side. So he has a VCSS of 12 on the left. As with all my patients in the office, I do an ultrasound at presentation. So here's his ultrasound, and here's his right common femoral vein. Here's a longitudinal view, color with spectral Doppler. And the first thing I want to point out to the, again, junior members of the audience, you have very flattened, dampened waveform in this right common femoral vein. And that's usually indicative of some sort of central venous obstruction or more. It could be compression, it could be post-thrombotic disease, but there's some decrease in respiratory phasicity, which is important to delineate. Then we go down to the common femoral vein. You can see with compression, it fully compresses, but when you look at the non-compressed view, you see this web in the right common femoral vein. So clearly his history of protein S, his history of DVTs for 40 years or almost 50 years, clearly had an impact on his venous system. Going a little further down the leg, here's his femoral vein and popliteal veins. You can again see they're compressible, but there is some post-thrombotic change in them. You can see this echogenic calcification and scarring within the femoral system and popliteal system as well. And then we do reflux exams. So this is standing with augmentation in the common femoral and femoral vein. So to give you that interconnection between deep vein obstruction as well as deep vein reflux, here you can see following augmentation, there's 3.6 seconds of reflux in the right common femoral and 4.2 seconds of reflux in the right femoral vein. So clearly he has deep venous insufficiency as well as chronic post-thrombotic changes in his veins, which usually go together, usually are correlated. Then we look at his superficial system. So I asked you earlier, is this deep venous obstruction alone, deep venous reflux, combination of deep and superficial? And I'm starting to show you that maybe it's a combination of both. Here's his saphenofemoral junction. Here's a pulse wave following augmentation, 5.6 seconds of reflux. For the junior people in the audience, again, anything greater than a half a second in the superficial system is abnormal. So this is clear reflux at the saphenofemoral junction. Is a dilated great saphenous vein of 7 millimeters and 3.5 seconds of reflux extending down the GSV in the thigh. So those varicosities that we saw in his thigh are not just collaterals to his obstruction, but really are reflux disease and varicosities or superficial venous disease in addition to his deep vein obstruction. So again, so is this deep obstruction or superficial reflux? Sounds like both. Can it be? I think it can be. So let's look. My preferred way to evaluate the iliac venous system is with ultrasound in the office. So while I'm doing that superficial study, I'll keep moving centrally, have the patient lie down, and then we'll image the iliac veins as well with ultrasound. So here you can see the iliac confluence. Here's the right common iliac artery. Here's the right common iliac vein. You're seeing the left common iliac vein or left common iliac artery over here coming down out of the screen. His right common iliac artery clearly looks abnormal. You can see it's small. It's only 6 millimeters. For those who don't know, a normal common iliac vein is about 14 to 16 millimeters. You can see also some webbing centrally within the common iliac vein here. So clearly more of that post-thrombotic change that we saw in the common femoral, as well as the femoral and popliteal, extending all the way up to the iliac confluence. Here it is with color Doppler. You can see there's trickles of flow, not full flow through that area. So you clearly are seeing chronic post-thrombotic changes. As we extend more peripherally, here's his right external iliac vein. You have great flow in there as well. But as you get more peripherally, you can see this arrow pointing to this thick calcified area of webbing within the right external iliac vein and extending to the common femoral vein. That's pretty severe. And then as we looked more centrally in the external iliac vein, again, you can see that webbing running through here, as well as a small narrow channel, only 7 millimeters in the right external iliac vein. We sent this person for a CT just to get more complete evaluation. Unfortunately, the timing of the CT is not ideal, so you're not really seeing contrast within the venous system. There's a little more contrast in the arterial system, but if I pause this and run this through, and I'm going to show you some still images in a second, you can clearly see as we come down, as I pause right here, it looks like where the internal iliac vein is joining, it looks compressed here between the psoas muscle and the artery. And then as we go further down, it looks like it starts to get this calcified webbing that we saw in ultrasound extending in there. Now, what's impressive about this is you don't see a really small caliber right common iliac and external iliac vein. It doesn't look like a severely post-thrombotic system because it doesn't look very small in caliber. But I'll tell you that if you look at CT alone, you're going to miss a large number of these patients who have post-thrombotic changes centrally within the iliac system. And so this patient, here's some still shots of those images looking at those areas of compression that we identified in that area of calcification. But like I was saying, you're going to miss a lot if you're utilizing this only to diagnose post-thrombotic changes in the iliac system. And we knew it was worse than that based on his ultrasound images that we did in the office. So we brought him for venography and intravascular ultrasound. And clearly you can see, here's a right common femoral venogram. And here's coming up, you can see these large pelvic collaterals going in here, reflux through the internal, here crossing over and trying to escape out the other side. You can see this web right here in the common femoral and into the external iliac vein with a split all the way throughout the common iliac vein and very sluggish, slow flow from that right leg. So this patient had been seeing vascular medicine for years and has not been intervened on since the 70s for chronic post-thrombotic change that's causing severe symptoms in that right leg. Then here we look at the intravascular ultrasound. Here's the probe at the center. You can see the vein around us. You can see the artery going by on the outside, and you can clearly see the spoke wheel webbing throughout the entire length of this iliofemoral venous system, from the IVC down to the common femoral vein, clearly causing venous obstruction, venous hypertension, and severe disease. And probably that venous hypertension has led to his superficial venous insufficiency. And you may be able to fix the deep obstruction, but treatment of the superficial side may also be necessary to get his leg better. So what's the best treatment for this patient? And this is really an important question that we don't know the answer for. And that's really where the C-TRACT trial comes in. I don't know if everybody's familiar with the NIH-sponsored C-TRACT trial, but this has been ongoing for about 2.5 years. It's an extremely important study to evaluate the value of deep venous interventions, venous reconstruction, to prove the validity and the utility of stenting people's iliac veins. And if we don't fulfill this and we don't get good randomized clinical data, we may lose the opportunity to get insurance approvals for these types of procedures, much like we have in other areas of IR. And so this is an extremely important and valuable piece of research that's ongoing right now. And the the background of this is disabling iliac obstructive post-thrombotic syndrome can cause chronic leg aching, fatigue, heaviness, swelling, and skin changes. And 20% of patients with central deep vein thrombosis with central post-thrombotic changes, like I just showed you, have moderate to severe PTS. And it can have a major impact on quality of life, much like I'm showing you in the patient that I just presented, as well as some of these pictures here where you can see ulceration. And if we look at the data on iliac vein stenting, there's clear data showing that there's benefit for iliac vein stenting in reducing pain, in reducing swelling, in reducing ulcers, basically promoting ulcer healing, and improving quality of life. And in a meta-analysis of over 1,000 patients, we saw a resolution of pain, swelling, and ulceration in 60 to 70% of patients who received stents with very low complications rates. So this is why there's such a move for people to do deep venous reconstructions and deep venous recanalizations, and why they're so important to our patients. The C-TRACT trial is what's going to validate this and make sure that retrospective data, that cohort data that I just presented, is really valuable and true. And without it, we're going to potentially lose funding. So here's where we are with the C-TRACT trial. Dr. Vedantam at WashU gave me this slide. He just presented it actually this morning at a C-TRACT trial meeting. And the goal of the trial, it's 2.5 years in, as I mentioned, the goal is to enroll 374 subjects. Right now, after 2.5 years, we're 92 subjects enrolled, which is very far behind schedule. And so we need to work hard to enroll more patients who have disabling obstructive post-thrombotic syndrome and iliac vein obstruction and evaluate them to see if they would qualify for the trial. And if so, they should get randomized to conservative care, which is great clinical care. They get compression stockings, they get anticoagulation, they get high quality clinical follow-up, to patients getting our interventions with iliac vein stenting, because I think good enrollment of high quality patients will lead to excellent results in showing the value of our interventions. And this is really important. SIR has backed this, the American Venous Forum has backed this, and some of you may have seen this email from the SIR Foundation last month, study before stent. And so this is a big promotion to get C-TRACT out into the public, out into the community. And those of you who are seeing patients, who I'm sure everybody is seeing patients with leg swelling and chronic deep venous obstructive disease, to try to shift these patients to get enrolled in the C-TRACT trial. And locally within the Philly area, these are the sites that are available. Obviously, I'm a site PI at Jefferson. Temple has a site, Dr. Bashir. There's also one at in Delaware. So there's definitely sites within the Philly area to get involved in the C-TRACT trial. So I want to show you another case in kind of angio club format. Here's another patient that I saw recently, 41-year-old female, history of multiple prior left lower extremity deep vein thromboses starting in 2011. She previously had treatment of that left lower extremity with thrombolysis and had left iliac vein stenting. Her left leg was doing well, and then before seeing me, had right lower extremity swelling, went to her local ER, was diagnosed with a DVT, initially treated with anticoagulation, returned to the ER several weeks later with worsening right leg swelling. At that point, 9 weeks post-acute onset of deep vein thrombosis, and has these ultrasound images. You can see this very echogenic thrombus within the right common femoral vein at the saphenofemoral junction, lack of compressibility. And then on color Doppler flow, this image is important. So here's the common femoral vein, here's the profunda femoral vein, here's the femoral vein, and you can see there's really no inflow from either. There's no inflow from the profunda and no inflow from the femoral vein. And this is an important point because this is really what is required for venous patency. And nobody, no matter what you can do with reconstruction, if you don't have inflow from either of those two vessels, your deep venous reconstruction in the iliac system is probably not going to work. So this should be a hard stop point for those of you out there who haven't done a lot of these interventions to not intervene on these patients. So this patient was at 9 weeks, and basically when I saw her, I said, you know, you're really in the subacute phase. There's not a lot we can do with thrombectomy. There's not a lot we can do with thrombolysis. None of those tools are really going to work for us. And you're still within that subacute time period where you're really prothrombotic, and any interventions we do aren't really going to help you. And so we decided to wait a few more weeks and see how she did. So we brought her back in the office 3 weeks later, and this is what she looked like. She had pretty swollen right leg. Her leg, I will tell you, is much better. I didn't include here a picture of her in bed in the hospital when she was much more immobile, but her leg is starting to feel better at this point. And I think that acute inflammatory process is starting to resolve at this point. And she was starting to feel better and be able to be more active, but that leg was still swollen, painful, uncomfortable. So here's her ultrasound, and you can see clear, complete occlusion. So here's her IVC confluence, right common iliac artery, right common iliac vein, left common iliac vein. There's no color flow. There's minimal color flow coming in the left common iliac vein. Going down the right, here's the right external iliac vein, which is occluded. This is the artery. Here's the internal iliac vein with some flow in it, and it's retrograde down into the pelvis. And here you can see more peripherally in the or more centrally in the common iliac vein. Again, no color flow, completely occluded right common iliac. As we get down to the right groin, you can see a dramatic difference from the ultrasound images that I showed you before. So here she started to recanalize her deep femoral vein or profunda femoral vein, and she's starting to have some inflow from the femoral vein as well. So she's converted, and that's probably why her leg is starting to feel a little better, is she started to recanalize those systems. Not only that, this is critically important for us because this is the inflow that we need to go ahead and do any sort of deep venous reconstruction in the iliac system. Just to show you here images of her left common iliac vein, you'll see in a minute on a CT, she had a previous left common iliac vein stent that was in there, and this is just showing you that left common iliac vein system is occluded as well, even though she's asymptomatic on the left. So we get access to the right popliteal vein since we know she had some femoral vein disease as well, and we wanted to get good inflow. So here we are. You can see these initial venograms. Here at the adductor canal, you can see complete occlusion of the femoral vein with going out into this collateral here that probably joins into the profunda and then eventually empties into that chronically occluded common femoral vein. And then as we do a venogram more centrally in the common femoral vein, this is a great point of interconnection. Here you can see how the common femoral is occluded, and right here through the obturator vein, all of her flow is entering through the obturator vein, going into the pelvic reservoir, the pelvic variceal bed, and all of her outflow from her leg is through the internal iliac vein on this right side. And so if I showed you these same images, I showed a still image and told you I injected from above, and this is what I saw from an ovarian vein, you'd clearly tell me this is pelvic venous disease. So you can see how all of these systems can be interrelated. And if this person had this from a pelvic venous injection and it refluxed out this obturator vein, they probably would have lower extremity symptoms because of reflux down the right leg instead of remaining within the pelvis. So here we are a little more centrally. Here you can see an injection at the iliac confluence. Again, chronic post-thrombotic changes all the way up to her IVC filter. We inject the left side. You can barely see on these digital subtraction images. There's a stent here that's completely occluded. And again, you see similar anatomy, collateralization through the obturator vein into this large left pelvic reservoir and escaping up through the left retroperitoneum. Just to show you, intravascular ultrasound is critical for venous evaluations. You can clearly see the IVC before. As we pull down, you're seeing here that occluded iliac venous segment. And you can see as we go down, you start to see post-thrombotic changes as well as webbing, just like you saw on the percutaneous ultrasounds that we did of the leg. But again, pretty severe chronic occlusion of the entire iliofemoral system. So we get through that whole system. I'm not going to bore you with the details of what we did throughout the case, trying to move this along. Here we did forceps retrieval of that IVC filter that was chronically embedded. And then we did venous reconstruction and stenting. Wow, I fast forwarded through something that took us a lot of time, but you can see clear, brisk venous flow, significant change in the venous outflow, nothing collateralizing through those obturator veins and through the pelvic vasculature. And then on intravascular ultrasound, this is just one of the sides, you can clearly see those open venous stents that are anechoic with nice patent lumens extending all the way down. Brought her in for 2-week follow-up. Here's her ultrasounds. You can clearly see brisk patent stents, antegrade flow in the internal iliac vein. Again, right side external is open, right common femoral is open. Left side, we got through that stent on the left. Again, you can see patent segments on the left side as well. And then all the way down to the left common femoral vein. And then from pre-intervention to 2 weeks post-intervention, clear dramatic changes in leg size and leg symptoms right away. So that's this half of the algorithm, this half of the side of the process, deep venous reflux and deep vein thrombosis and deep obstruction. So what about this other side of this process that's even more interconnected? Let's talk a little bit about the superficial and pelvic venous disease side. So start with an example. Here's a 38-year-old female, 3 prior pregnancies. She had varicose veins for 10 years. She had prior bilateral great saphenous vein ablations before ever coming to see me. She presents to the office, and here she clearly has C2 disease, so SEEP classification. She has varicose veins in both legs, you can clearly see, without swelling or skin changes. So she falls into C2. Her VCSS is 6. She has bilateral leg heaviness, fatigue, and throbbing. She also has right groin and labial varicosities that she's talking about. And she has labial fullness and throbbing with menses, and it lasts for several hours post-intercourse. She did not have any of these pelvic symptoms 10 years prior when she had the bilateral great saphenous vein ablations, but she's clearly recurring with lower extremity vein disease and has lower extremity symptoms as well as lower extremity varicosities after prior treatments. And now she's starting to develop these pelvic symptoms years later. And so here's her imaging of what it looks like. Here's an MRI of the pelvis. You can clearly see her uterus here, and you see these dilated venous segments on the left side of her pelvis. And if we look a little higher, you can see compression of the left common iliac vein under the right common iliac artery. And then if you look even higher, right here next to the, you can see the right ovarian vein and the left ovarian vein, and they're dilated. I won't show you measurements on these images, but there definitely are dilated and refluxing. So how do you treat this patient? You have a patient who has lower extremity symptoms, pelvic varicosities, and lower extremity varicosities. Do you treat the legs or do you treat the pelvis? I would say patients come first. So let's treat what's bothering the patient most importantly. But knowing that if the legs are still the biggest problem in this patient, she's had multiple recurrences after lower extremity treatment and probably has a pelvic source. So if you keep treating her lower extremities, she's going to keep returning year after year with recurrences because you haven't treated the underlying cause that's in her pelvis. And which are you going to treat? Are you going to treat her left common iliac vein compression, or are you going to treat her ovarian vein reflux with ovarian vein embolization? So I like to look at these with ultrasound. So here's some ultrasound images to try to get quantification of where I think the pressure problem really is. So here are central images of her left common iliac vein. Here's her spine right here. Here's her left common iliac vein draped over the spine. Here's her right common iliac artery. The right common iliac, or the left common iliac vein, 7.4 millimeters here at the area of compression, 8.5 millimeters a little more peripherally. You can see clear antegrade flow. There's no aliasing or change in velocity here. And then most importantly, look down at the confluence of the internal and external iliac veins, because if there is obstruction in that central left common iliac vein, you're going to look for reflux in the left internal iliac vein to see if it's backfilling into the pelvis. And here, if we look at the map, you can clearly see red flow is towards the transducer. So our internal iliac is flowing towards the transducer, which means it's antegrade flow in the internal iliac vein and not retrograde flow. So again, that's pretty indicative, or can be indicative, not 100%, but can be indicative that this obstruction or this compression is not physiologically significant and that we don't have to deal with that first. So we can deal with the ovarian vein first. Here's some images of her pelvis with ultrasound. You can clearly see those veins in the pelvis. They measure up to 9.5 millimeters. The newest definition of pelvic venous disorder says that a vein bigger than 5 millimeters in the pelvis is significant. So you just need at least one vein bigger than 5 millimeters in the pelvis. So she clearly qualifies as pelvic venous disorders based on that definition and pelvic pain. And then if we look at the ovarian veins, here's our left ovarian vein, which is 6 millimeters and has, again, retrograde flow. This is central, this is peripheral. Blue is towards the transducer. This is retrograde flow in that left ovarian vein. So we have a refluxing left ovarian vein leading to pelvic venous disorder. So we decided to proceed with left ovarian venogram and embolization. Here you can see a left renal vein injection. You can clearly see reflux down into the left ovarian vein. This is with the patient supine and sedated. They're not in Valsalva. They're not, and they're not tilted on a tilt table. So clearly there's free reflux down that left ovarian vein. Again, by venography, it measures 6.3 millimeters, similar to what we saw with ultrasound. So that's coordinating that. My technique for treating these, I put an occlusion balloon down in that left ovarian vein. I inject the pelvic reservoir with sclerosant, which is what we're doing here, and then coil that left ovarian vein to occlusion, which is what you can see happening in these images over here. You can see nothing flowing retrograde down into the pelvis anymore. We were not able to get into her right ovarian vein in this particular case, but I always check the internal iliac veins as well to make sure there aren't any residual varicosities that need treatment. Here you can see interesting anatomy. We're in the internal iliac vein, and you can see it has a separate connection from the pelvic veins to the external iliac vein here as well. And this is a common duplicated connection here, and it's just outflowing very briskly, and there aren't pelvic varices arising from the internal on either side. So then she had persistent vulvar and lower extremity symptoms. So we started, once we treated from the top, now that we've treated top down, we felt comfortable starting to address and eliminate her vulvar and lower extremity varicosities with confidence that they weren't going to lead to rapid recurrence like she was having happen in the past. So the next way we treated that was percutaneous sclerosis of the vulvar varices. I did it under fluoro in her particular case so I could see if there were any connection points to pelvic reservoir veins. So 25 gauge needle into one of the vulvar veins under ultrasound guidance. This is 3% STS mixed 1-to-1 with contrast. So 1.5% STS injected under fluoro to fill that entire variceal reservoir. She had bilateral vulvar varices, so we accessed both sides individually. And then afterwards, I put these patients in compression, so you can use something like a V2 supporter, which is a compression underwear garment. Most patients don't like those, so I usually have patients purchase Spanx, and they use Spanx for compression to compress these veins to allow them to close and minimize trapped blood, which you can get and can be very uncomfortable in this particular location. So when should you look for pelvic source? When should you look for pelvic source varices in the lower extremity? And this isn't that clear, but it's pretty common. 1 out of 6 varicose vein patients have a pelvic source. And so whenever I see patients in the office for lower extremity varicosities, and if I see an abnormal, or I don't want to say abnormal, whenever I see a less common presenting pathway of reflux. So let's say I don't see saphenofemoral junction insufficiency, or let's say I see a lot of varicosities joining the GSV in the upper inner thigh. I'll start to ask the patient if they have vulvar varices or if they have pelvic pain, if they have postcoital pain, importantly, because I think these are important for us to recognize. And many patients, because they're coming to you as a interventional radiologist and you're really a vein specialist, they're there to see you for varicose veins. They don't even think to present to you about their pelvic pain symptoms. So it's important to ask. And there's definitely a degree of overlap between pelvic venous disorders and lower limb varicosities. So what's the data show us about that overlap? This is a great study by Kathy Gibson looking at comparison of histories, demographics, and clinical presentations of women with perineal vulvar varices to those with non-pelvic source lower extremity varicose veins. And the women with pelvic source varicose veins were younger, had significantly lower BMIs, and had larger infant weights. So to me, that indicates maybe there's an obstructive component at some point in their lives that led to these pelvic source varicose veins, although it could be any source that's really leading to this. And up to 10% of lower extremity venous reflux arises from pelvic veins in women. And then what's interesting was the incidence based on symptoms. So if you look at this patient population, and only 7% of the, only 7% of them had pelvic pain or heaviness, but a quarter of them had dyspareunia. So again, that's why it's important to ask the question about postcoital pain. Even if it is uncomfortable for you or the patient, it's important to ask these questions to best diagnose what's going on in those patients. Then what about treatment? Here's a paper from about 6 years ago by Hartung looking at different treatments of pelvic-derived lower extremity varicose veins. And I think this is really interesting. It's a relatively large patient population, 119 patients. 86% had pelvic congestion, although they didn't state what the definition of that is. 102 had lower limb varicose veins. And if we look at the incidence and outcomes, so if they treated the pelvic veins first, so they did ovarian vein embolization, then looked at outcomes. 91% had improvement in symptoms. 51% had mild to moderate lower extremity symptom improvement, meaning half of them had improvement in their lower extremity symptoms. But just like the patient I showed you before, many of them and most of them needed additional therapy for their lower extremity. They continued to have some symptoms in their lower extremity, and 82% of them needed lower extremity treatment as well. So it's important. It definitely will reduce what you need. In some patients, you didn't need to do as much phlebectomy and could do sclerotherapy. But it's important to address in the right patients top down where the reflux starts to treat the entire course of venous insufficiency. However, this is a consensus panel from 2017 looking at pelvic venous disorders, and there's really no randomized controls trials. There's only single center studies. And these small series have failed to demonstrate a significant improvement in lower extremity varicose veins after only pelvic venous embolization. So it's important that we address what's going on and get randomized trials to understand the disease entity of pelvic venous disorders better. So how should we treat chronic pelvic pain from pelvic venous disorders? We've had some really good systematic reviews over the past few years. Many of you have probably reviewed this. This one from 2018 looked at almost 1,000 patients and looked at outcomes of different treatment algorithms for pelvic congestion or pelvic venous disorders. You could treat with coils, you could treat with glue and Lipiodol, sclerosis or sclerosing and coils. You can see sclerosing plus coils or coils alone were the two most common in all of these cohort studies that were reviewed as part of the systematic review, and they all basically indicate a great outcome. But I will suggest that it's probably better that you treat with sclerosing in the pelvic reservoir so that you can treat the entire reservoir and prevent against recurrences, which was not able to be analyzed in these retrospective reviews that are part of this systematic review. Here's another systematic review from another group looking at very similar studies and basically giving you very similar outcome data as far as the success of ovarian vein embolization. And then recently, just a few months ago, there was an article by Di Gregorio that was presented or that was published looking at a very large patient cohort. Again, this is a retrospective patient cohort, and they were looking at 4-vessel embolization with coils only and showed a very high success rate at reducing chronic pelvic pain in these patients. But I want you to take this with a grain of salt. This was a single center retrospective piece of data, and the majority of these patients that they recruited were patients with pelvic-derived lower extremity varicose veins, oddly enough. So there are mostly patients coming to the vein clinic with varicose veins that they were asking if they had pelvic pain and then treating that pelvic pain. So this isn't necessarily your pure chronic pelvic pain patient population. They had a high number of coil migrations because they did put coils in the internal iliac vein, which I would suggest against, and they also suggest against in their article. And then their mean time to improvement was very long. So is it really the value of their treatment that led to the clinical improvement? Iliac vein stenting is also important. There's 2 studies looking at this. Doherty looked at 19 patients with non-thrombotic venous outflow obstruction, showed clinical success and improvement in pelvic pain and dyspareunia in these patients after iliac vein stenting. And then a very popular article that's quoted by Santoshi showing a significant improvement in VAS scores in those patients who had iliac vein stenting in that population as well. So in summary, the evaluation of venous disease patients requires clinical skills and a complete understanding of all the components and interconnected relationships between the venous segments and venous systems. Ultrasound is an excellent screening tool, can be utilized to assess all patients for deep, superficial, and pelvic venous disorders. And randomized controlled data is badly needed in multiple aspects of venous disease. The C-TRACT trial, most importantly right now, that's ongoing. We need to recruit patients into this trial so we can continue to do these interventions and be validated in our treatments. And upcoming pelvic venous disorders require randomized controlled data to prove efficacy of intervention and improve decision-making for embolization versus stenting. I hope to tell you that in the next 6 months, we should be opening a multi-center trial on this. That is in the works. Funding is being planned, and hopefully we'll have that ongoing in the very near future. Thank you all very much for paying attention. Look forward to answering some questions from the audience.
Thanks, Ron. That was great. That was pretty comprehensive. We do have a few questions. I'll kind of read them off to you. Some of this you did talk about. This question came in pretty early. At some point, can you please talk about your workup imaging strategy for suspected pelvic reflux disease? I know you talked about the ultrasound as far as in the office, but I guess maybe off of that, when are you thinking more MRI, CT, or where does that come into play?
It's a great question. It really depends on what you have access to in your office. I'm lucky enough, I have an RVT with me in the office at all times. And I've taken the time to train that RVT, and I spend one-on-one time in the office doing all of these ultrasounds to evaluate these patients and to look at the iliac vein segments for both obstruction and ovarian vein reflux. So it's really important for me to have that skill. I think I'm able to get important workup information as far as the physiology, and I'm able to get more accurate information than I can often get from CT or MR. However, if for whatever reason, Philadelphia, we have much larger patients, so it's very possible that I'm not going to be able to get that imaging, and I'm not going to be able to see deep enough to visualize the ovarian veins. In those cases, I'll usually get an MRV, and I think that's the best tool to use in the pelvic venous disorder population. If you don't have access to ultrasound, because you can get MRV, you can get time resolved imaging, you can get physiology, so you can diagnose reflux in those ovarian veins, as well as just anatomic information. And then also we're often thinking about a young patient population, maybe 20 to 40. And so we don't want to expose that patient population to excessive radiation with CT. So MR is going to be a better tool in that particular setting.
Okay. What's the underlying pathophysiology of the spoke wheel webbing seen on IVUS?
Oh, so that's a great question. I've wanted to publish on this for many years. I probably shouldn't say this in a public audience. I think there's multiple different patterns of post-thrombotic syndrome that you clearly see. And if I wanted to delineate all of them, I think they basically involve the most common one, small venous caliber. So the vein's going to constrict down and become very small after they heal the acute DVT process. Wall thickening is another common one. So you might see a normal caliber vessel with intimal hyperplasia and wall thickening. You may see a combination of the small vessel and wall thickening. You may see mural thrombus or mural scarring in mural fibrous tissue that takes up some component of the lumen, which is again another common pattern that we see. Webbing in synechia is another extremely common one, like that spoke wheel webbing that I showed. So as patients heal their acute thrombus, they basically get fibrous tissue deposition, and depending how the body heals and clears that thrombus, you either get complete clearance, pushing it to the side, or you get that spoke wheel webbing kind of pattern. So that's my theory. I don't think we have a lot of data to tell you why that happens, but those are the different patterns that I've seen over time.
Okay. For the ovarian or gonadal vein embolization, you'd mentioned using a sclerosant. What's your cocktail? So what's your concentration? Do you use foam, do you use CO2 or room air?
So I use Tony Venbrooks's secret cocktail. He gave me this cocktail many years ago. So 16 mLs of contrast, 4 mLs of 3% STS, and half a brick of gel foam. And I leave the air in the gel foam. And so that makes a nice thick foam slurry. And the reason I use the gel foam, I know it creates a little bit of more of a thrombotic reaction in the pelvis. So my patients have a little bit more pelvic pain post-procedure from that. But what the foam does is it creates a thick slurry, and it doesn't fly through the pelvic reservoir and escape out the other side or escape into the internals very quickly. It helps it sit stagnant within the pelvic reservoir. And that time that the sclerosant sits stagnant, I think leads to a better result at closing those veins.
That's
Ron,
interesting.
quick question. Stephen Hunter. Do you know if there's any data on either drug-coated balloons or kind of the comparison of just plain old balloon angioplasty in a lot of these segments, particularly obviously the legs where you're not doing a lot of stenting necessarily on the posterior thigh and stuff?
There is no data that I'm aware of published yet on DCB for chronic post-thrombotic change in the femoral or fempop or I guess common femoral segments. I will tell you anecdotally, I have tried it because the thought has crossed my mind with such great outcomes for venous outflow stenosis with hemodialysis circuits. I did try it, probably it's now been 6-7 years with small drug-coated balloons. So that at the time we only had up to 7 millimeters. So that was the biggest I had. And I used that in the femoral vein. Didn't have a great result, but I do think that there's potential for using drug-coated balloons in this patient population, and something I've brought up to some of the industry reps to potentially look at a trial in the future.
With iliac stenting, are you, I guess, what's the equipment you're typically using? Are you using wall stents? I know there's some newer venous stents that have kind of come out to market. I think Boston Sci has like a Vici stent that they kind of promote as like having a little bit more radial strength. So I just didn't know if you've kind of switched anything you've been doing from an equipment standpoint.
Yeah, I've been involved with venous stents since the beginning. So the Vici stents, I was on trial for when they were being developed and during their initial phase out. And I've basically used Vicis, Vinovos, Abres. I have not yet used the Silver Vena, which just got approved within the past month. So hopefully I'll get my hands on those as well. I have shifted to vein-specific stents and the newer designed self-expanding nitinol stents over wall stents entirely. I think the accuracy of deployment is much, much easier. It makes this process much more straightforward. The accuracy of landing these stents is very easy. The click wheel deployment compared to what we used to use with wall stents is much better. I do think we get the radial force. There's some questions of extending the newer venous stents across the inguinal ligament, that there may be fractures across the inguinal ligament. So we do need to be careful about that and study that more in the future and figure out if they're safe to use across the inguinal ligament like we've done with wall stents for years.
Okay, so have you been avoiding doing that? You haven't been putting them across the inguinal
I
ligament at all?
I do actually put them across the inguinal ligament. I have not worried about it.
Okay.
I used to, forever, before we had any of these vein-specific stents, I used to use smart stents in the common femoral vein, and then I would support them with wall stents underneath. I don't like the edge of the wall stent in the common femoral vein. It's very sharp. And I used to get lots of spasm and stenosis in the common femoral vein right at the profunda and femoral junction. And I felt like that led to a lot of stent occlusions. And so I would use the edge of the smart stent and then just get radial force out of the wall stent underneath it. And so I think the vein-specific stents are much better in that circumstance. So I have been using them all the way across the inguinal ligament.
Okay. I think that concludes our Q&A session. I just want to thank you again for joining us this evening. That was a great informative talk. For all the attendees, just to remind everybody, for March, we don't have a meeting given the SIR meeting will be going on, but we will have a talk on prostate artery embolization in April. So look for that. Again, Ron, great having you. Awesome talk, and appreciate you being with us.
Thanks so much.
All right. Thanks, everyone.